Welcome to the first session of Breastics24h, Masters and Promises in Oncoplastic Surgery. We are honored to open this session by interviewing Professor Krishna Clough, one of the most renowned international experts in the field of breast surgery. Professor Clough is a surgeon, an oncologist, and a plastic surgeon. After completing his surgical training in France and in the United States, he joined the team at the Korea Institute in 1990, where he was soon appointed Chief of Department of Breast and General Surgery. In 2004, he founded the Paris Breast Center, the first center in France exclusively dedicated to breast surgery and breast cancer. Hello, Professor Clough. Thank you for being here with us today. And for
Good morning to all. Good morning.
Thank you, good morning. And thank you for offering us the opportunity of interviewing you. Well, you are considered one of the founders of oncoplastic surgery. You started publishing on oncoplastic surgery by the end of the 90s. What kind of apple fell on your head at that time when you started thinking about oncoplastic surgery? At that time, was your experience well received by the surgical community? Do not forget that oncoplastic surgery affects not only on treatment of breast cancer, but it has been a revolution even on training.
Well, what happened really is I was training as a breast surgeon and surgical oncologist, and across the room you could see the plastic surgeons doing plastic surgery of the breast, and the two specialties did not communicate. So if you would go to a breast surgical oncology operating room, people would excise 100 grams of breast tissue for breast conservation and leave a monstrous breast. And on the other side of the corridor, people would excise 400 grams for a reduction mammoplasty and leave two normal looking breasts. So at that time, we thought there might be a possibility to build a bridge, and that was the late 80s. And we started publishing in 1990, so unfortunately it's more than 30 years ago now, that it is possible to use plastic surgery techniques at the time of tumor excision. But we had two goals. Everybody's talking about cosmesis and cosmesis and cosmesis, but actually the two goals were, number one, reduce the deformity created by wide local excision. And number two, push the scope of breast conservation. If you can excise 300 grams for a breast reduction, why can't you excise 300 grams for a 5 centimeter DCIS? And the topic of our work over these 30 years was to demonstrate it was feasible, it was safe, it was reproducible, but it was not for every patient nor every surgeon. But we'll come back to that.
Thank you very much, Professor Clough. So every good idea starts as a very simple idea, and communicating, like in this case, in the case of oncoplastic surgery. Now, we read with pleasure your editorial that was published in 2019, The Oncoplastic Frenzy, Beware the Swing of the Pendulum. And we do agree that to a man with a hammer, everything looks like a nail. 2 years later, now we are witnessing a pursuit for even more complex surgery with extensive introduction of microvascular techniques, even for repair of breast conservation defects or post-mastectomy breast reconstruction. Do you believe that oncoplastic breast surgery is now over-mediatized? And are we hit by an OPS, an oncoplastic surgery fashion at the moment?
Well, the answer stands in many publications, including ours. We did a survey in France, and I published that in Annals of Surgical Oncology like maybe 5 years ago, in 25 expert breast centers, both public and private, over 15,000 breast conservation procedures in 1 year. All these centers train for oncoplastic surgery. We train fellows. The number of breast conservation surgery in France, including these 25 centers, is 72%. This is our national breast conservation rate. The number of oncoplastic level 2 procedures was 12%. So actually, there's a lot of mixing between fiddling around with breast tissue, doing a periareolar scar to go an upper outer quadrant, and what we have defined as level 2 procedure, which means mammoplasty technique with en bloc skin resection for large excision. So if you're only considering these level 2 techniques, and our classification was endorsed by the American Society of Breast Surgeons in the Chatterjee Journal, so actually this was our work in 2010, it's only 12% of patients. If you encompass all the level 1 procedures, then it will be probably something like 60 to 70%. But you don't need to be a plastic surgeon to do level 1 procedures. You do need to be trained in plastic surgery to do level 2. And we'll come back to that because I think you have a question on training. So yes, if you're talking about level 2, I think oncoplastic surgery is very mediatized because a lot of people think about mixing level 1 and level 2. Any breast surgeon, in my belief and in what we train our fellows doing, should be able to do every level 1 procedure. This is standard breast surgery to us. Level 2 with mammoplasty or perforator flap are more complicated and need a longer training.
Thank you, Professor Clough. A very clear message for all breast surgeons. Well, we recently published a grade-based systematic review, and we demonstrated that oncoplastic breast conserving surgery still relies on a very frail level of evidence. You are one of the founders. Why does it happen? Is it because the benefits of oncoplastic breast surgery are self-evident, or because certain treatments cannot be tested in randomized trials?
I think the key answer to your question is what we just stated. There's a massive mix between little cosmetic procedures through the areola and excising 400 grams for a bilateral mammoplasty or putting in the LTAP or LICAS. I think one of the very complicated visions we have about oncoplastic surgery is all these breast surgeons around the world who have discovered oncoplastic surgery, but who have no clear guidelines about what is level 1 and level 2. This is number 1. Number 2, as surgical oncologists, our key points are survival, recurrence, and quality of life. But first, survival and recurrence. Well, you have no randomized study between oncoplastic and non-oncoplastic. And I could say the first randomized study was probably Umberto Veronesi comparing quart to tart, because this was a non-oncoplastic wide resection, and Umberto demonstrated that he would have the same survival and less recurrence. If you look at the endpoints, which are resection volume, recurrence rates, positive margins, reoperation rates, we have demonstrated in a paper we published in Annals of Surgical Oncology as others, and the Losken meta-analysis states that oncoplastic surgery allows wider resection volumes than lumpectomy, less reoperation, and the longitudinal unicenter study demonstrate that we obtain a 5-year recurrence rate for large tumors operated by oncoplastic surgery, identical that small tumors operated with a lumpectomy. But if you're talking about randomized study, we will never have one. Because we're not operating the same tumors. We are doing level 1 procedures for cancers that are 5 centimeters. Some people are, level 2. Let's do that again. We are doing level 2 procedures for large cancers. Most of the surgeons do mastectomies for these large cancers who do not respond to chemo. So we are not talking of mammoplasty for 1.5 centimeter cancer.
Okay, Prof, thank you very much. This is a very clear answer. Let's talk about the future now. Tell us 2 or 3 hot topics for oncoplastic surgery in the next 20 years. And what about the training of oncoplastic surgeons? Could you give them, the junior trainees, a few suggestions to improve their skills? What should they focus to become a good oncoplastic surgeon? Thank you.
Well, I don't know about the future of the techniques, because as you stated, everything is going in every direction now. Mammoplasty, perforator flaps, microsurgery for breast conservation. I think the key point is training. I think the time where breast surgeons who were doing breast only were capable of doing a lumpectomy or mastectomy is over. If you want to be a breast surgeon, you will have to train in at least level 1 oncoplastic procedures, remembering that level 1 oncoplastic procedures are very quick to learn, and they are based on leaving a normal looking breast after a lumpectomy. So I think that all these level 1 procedures should be incorporated into breast surgery. We have visitors coming from all over the world at the Paris Breast Center, and I'm very surprised to see breast surgeons age 35 or 40 years old who tell me they've never done a glandular flap, or they've never recentralized the nipple areolar complex, which to us are basic, and everybody should be able to do it. If you're looking at the other scope, which is perforator flaps, mammoplasty, maybe sponges in which you inject fat grafts, because we didn't talk about fat, but actually fat grafting is going to be a major tool in breast surgery in the years to come. Major tool, which is for the moment not being experimented in the breast conserving surgery technique, but what we see for total reconstruction of the breast with fat graft will certainly impact breast conserving surgery. So training is key. I think any young breast surgeon should be able to do every level 1 procedures, and everyone who wants to do breast surgery only, because don't forget that in the vast majority of the world, breast surgeons do breast and general surgery, or breast and GYN. But the ones who want to be breast surgeons only definitely will have some training in level 2 techniques with everything we've been talking about. Microsurgery, fat grafting, implants, new technologies that we don't imagine today. So there will be, I think, 2 kinds of surgeon. General or gynecologic surgeons with a special interest in breast, level 1. And those breast surgeons who do only breast, I don't think they can continue doing excisional surgery only. They will have to encompass plastic surgery training. For example, if we talk about the United States, for the moment, it's not possible. In Europe, we all do it. In the States, there are some difficulties having that dual training.
Thank you very much again. And Nicola?
Many thanks, dear Professor Clough. It has been a great pleasure to have you here today with us. Thank you.
Thank you
for taking